Hello everyone and welcome to Indian Radiologist. My name is Dr. Sanjeev Mani, and in today's tutorial we are going to be speaking on ultrasound of the neck. This is a basic tutorial in which we will be displaying the anatomy of the neck as we scan the patient, and also I will be speaking on common conditions that we expect to see in the neck as well as a few uncommon ones. So this video is about examination of the neck by ultrasound, and we usually get referrals because of a thyroid lesion which may be seen by the clinician or because of enlarged lymph nodes. These are the more common indications that we come across while scanning the neck. So while scanning the ultrasound of the thyroid, how we start is by placing the probe in a transverse fashion across the neck, at the base of the neck. We usually start by seeing the thyroid gland in the transverse plane, as we can see here, but it's a good idea to start a little below that. So we would like to start here from the suprasternal notch. In fact, you can see the innominate artery right here, and from here you gently move up until you locate the thyroid gland. Now it's again good to move to a virtual convex or a trapezoidal plane like this. So what happens is that you get a greater view of the thyroid gland. So we can see both lobes here. This is the right lobe, that is the isthmus or the bridge of the thyroid gland, and here is the left lobe or the left hemithyroid. So we continue to scan this patient by gently rocking the transducer to and fro, going down. This is the inferior poles right here, moving up to the mid region, and then the superior aspect of the right hemithyroid here. Once we are done here, we turn the probe 90 degrees and make it a longitudinal plane. So again, we can see the thyroid gland right here. This is the superior aspect, this is the inferior aspect. These are the strap muscles here of which lie anterior or superficial to the thyroid gland. Note the echo pattern of the strap muscles. They are much lower than that of the thyroid gland that is seen here. So we finish seeing the right side. We look for change in echo pattern. We look for any nodules or mass lesions. Come back transverse, move across to the left side and start reviewing the left hemithyroid. Again, go down, mid region, superior pole. We're convinced that there's nothing here. Again, turn, make it longitudinal, and have a look at the thyroid gland again in the longitudinal plane. Once we finish seeing the thyroid gland, we move to the adjacent structures. So as I move here gently to the right, you can see two structures which are equipolar. So we know these are vessels. This happens to be the common carotid artery. This is the internal jugular vein. The structures above here are the sternocleidomastoid muscle. We look for nodes adjacent to the internal jugular vein right here. As we move upwards, we continue in the path of the common carotid until we see its bifurcation. You can see it here, bifurcation into the internal and the external carotid arteries. Go back down, look at the carotid bulb, go up again, and that happens to be the bifurcation. We do this on both sides. Still above that, in the same plane, as you reach the angle of the mandible, you can see another structure right here. It's oval, it's a little bright. The echo pattern is almost like that of the thyroid gland, and this happens to be the submandibular gland. And you have to again look at the gland architecture as well as look for focal nodules or an enlargement of this salivary gland. We also move in the preauricular space and look at the parotid gland. So this is how we see the parotid gland. It's a thin structure. We can only see the superficial part of the gland, not the deep portion. And you see the gland right here with a small intraparotid node, which is pretty commonly seen in the parotid gland. So this is how we do the basic scanning of the thyroid gland as well as the neck structures. Now let's talk a bit about the lymph nodes. Now these lymph nodes are pretty commonly seen, and we see them more commonly at level 1B as well as level 2. So when we start seeing lymph nodes, you usually see them as a hypoechoic structure. It is seen usually on both sides, pretty commonly seen in fact. So how can we differentiate normal from abnormal? And there are certain criteria which are pretty much established, which tell us how to evaluate the cervical nodes. So we evaluate them for size, morphology, echogenicity as well as color flow. So while assessing the lymph node for size, we assess it in the short axis. So we take the maximum measurement in the short axis, and this measurement should usually not be more than 8 millimeters. But size is not the only criteria to evaluate cervical nodes, as certain nodes can also be elongated and can be as much as 2 centimeters long. So we also look at other factors. We look at the morphology of the node. Now the node, as you can see here, is a classic cervical lymph node. This has to be oval and usually not round. We look at the echogenicity. It should be uniformly hypoechoic and it has a central bright hilum. On that central bright hilum, if you put on color, you will see hilar central flow. We can see a small little artery here as well as the vein exiting out. So this node has all characteristics of a normal lymph node. Now let's try to see how abnormal nodes look like. So that is the submandibular gland right here, and just next to it we can see this much larger node. Yes, it does have a central hilum as you can see here, but the lymph node is far hypoechoic. You can see another adjacent node there, but this is the one that we are looking at. This lymph node was tender for the patient and the patient also had fever. When we put on color, you can see a slightly increased vascularity in the node. Now let's compare this vascularity that we see in this node, which is an infected node, versus a regular hilar node. So we can see on the left of our screens an inflamed node with reduced echoes as well as increased vascularity. Whereas on the right side, like I showed you earlier, this is a regular lymph node with normal hilar vascularity. Now here's a look at another lymph node. So this lymph node shows linear striations. There is loss of the normal hilar architecture. You can see a small lobulation at the superior aspect of the node. So this is an abnormal node. And when we diagnose abnormal node or disease node, it is best to undergo a guided sampling. Now in sampling, a true cut biopsy is usually preferred over an FNAC. And I have this nice pictures sent by Dr. Vishal Kumath, in which we see a nice simple video of lymph node biopsy being done. Besides lymph nodes, the other abnormal lesions that we see are thyroid lesions. So in the thyroid gland, usually we see two types of conditions. Commonly, one would be a focal nodule, which could be either hypoechoic or isoechoic or hyperechoic. And the other pattern that we should look for in a thyroid gland is whether the standard normal echo pattern of the thyroid gland is preserved or not. Now if you take a look at this picture, this is something which we see very commonly day in and day out. You are seeing a very well defined cystic lesion and it has got a very smooth margin. There is no calcification. This is a classic typical colloid nodule that we see. Now if you need to know more about thyroid nodules and the ThyRides classification and how to grade them, we have a great video by Dr. Alka Singhal on our channel. Sometimes, however, if the lesion is large and indeterminate, it's best to conduct an FNAC and get a conclusive diagnosis. The other pattern that we see is a change in the thyroid echo pattern. So let's have a look at this case. This is a 55-year-old male with fever and neck pain. And as soon as you start scanning, you see that the thyroid gland has lost its normal bright echo that we see. In fact, if you compare the echo pattern of the strap muscles to this thyroid gland, the thyroid echo is almost as low as the strap muscles. This pattern is seen uniformly across the thyroid gland. The thyroid gland is showing a slightly pseudonodular pattern, but no focal nodule is actually noted. We can also see slightly enlarged lymph nodes adjacent to the thyroid gland. These are central nodes which lie within or inner to the internal jugular vein. And when we see this picture of a heterogeneous echo or low level echoes within the thyroid gland with adjacent nodes, the diagnosis is usually thyroiditis. Now there are several causes that can cause thyroiditis, but the more common ones are the autoimmune ones. In this, the commoner of the two is Hashimoto's thyroiditis, that usually presents as hypothyroidism, and the other is Graves' disease, that usually presents as hyperthyroidism. On ultrasound, it is difficult to differentiate between these two, and serological markers are required for a definite diagnosis. Parotid lesions are usually another topic altogether, but like we said, we see the submandibular gland and the parotid gland, and we are more likely to see lesions within the parotid gland than the submandibular gland. Another rule of thumb is that usually parotid lesions are more often than not benign, almost 80% of them, whereas if you see a lesion in the submandibular gland, usually 80% would end up being malignant. So lesions in the submandibular gland, you would need to image further with a CT or an MR. Now let's have a look at this particular parotid gland case. As soon as we put the probe here, you may think that this looks like a cyst because you're getting almost an acoustic enhancement seen posterior to the lesion. But as you change the TGC settings, you can actually see that it is nothing but an intraparotid inflamed lymph node. Of course, you can see the normal hilar vascularity and the hilar architecture still maintained. Intraparotid nodes are pretty common in the parotid gland and can also get inflamed and give rise to pain. Now here's another interesting case, not uncommonly seen. Now this is a 2 weeks old neonate who had undergone a forceps delivery and has presented with torticollis. Now when we see this picture, of course, we can see here the thyroid gland, and on the left side, as we start scanning, we can see a focal area of heterogeneity within the sternocleidoid muscle. This muscle is bulky and is showing altered and reduced echos. We come to the right side just to compare, and you can see the flat, normal, smooth sternocleidomastoid very well seen. You see the thickness and you compare it with the left side. So let's go back to the left side, and again you can see a very thick muscle, and you know that this is a bulky and large sternocleidomastoid. No mass seen within it. Forceps delivery. The diagnosis here is pretty simple. This is fibromatosis coli or sternocleidomastoid tumor. Now here's the last case. This is a 40-year-old female who is on OCPs and had a twisting injury of the neck. She suddenly presented with a lump a few days after that injury. A video consultation was done with the ENT specialist and he asked for an ultrasound. So when this patient came for ultrasound, and we do our normal standard screening where we move adjacent to the thyroid gland, as you can see on the screen, and we see this lesion. Now you can see that this lesion is lying anterior to the right common carotid artery, and it has got altered echos, but if you keep tracing it back and forth, you will realize that this is actually nothing but a thrombus within the internal jugular vein. You can see here going superiorly right up and come back down again past the thyroid gland. The internal jugular vein joins the right subclavian, so we can see it here joining the subclavian, and the thrombus is actually almost projecting into the right brachiocephalic vein right here. So this is an uncommon condition, but the idea of showing this case also is that you can expect lesions almost anywhere in the neck. They needn't be just in the thyroid gland or needn't be just in large lymph nodes. And doing a thorough survey and analysis of all the structures that lie in the neck will help in reaching a complete and correct diagnosis. Thank you for your patient hearing.